We're now going to discuss some of the environmental concerns that we have when we're out in the wilderness playing. These include bites and stings and envenomations. Let's start with ticks. Ticks are a ubiquitous little creature. You find them everywhere and they transmit disease. There are lots of different diseases that ticks can transmit. One of the main ones, or at least the one that people know about, is Lyme disease. But there are other ones. Babesiosis, Rocky Mountain spotted fever, just to name a few. When it comes to ticks, the best thing is prevention. You want to make sure that the tick doesn't get on you. How do you do this? You can use tick repellent sprays, wear long clothing, keep your pants tucked into your boots, your cuffs closed, but also remember to do tick checks every day when you're finished hiking or playing in the outdoors. However, you don't need to panic as much as people usually do when it comes to ticks. Yes, they're pretty disgusting little creatures, but it takes a while for them to transmit the disease. If you're doing a tick check and you find a tick on you, just remove it. How do we do that? You don't want to burn it. You don't want to smother it. You simply want to grasp it by the skin, down near the base, and gently lift it straight up. If you rip and tear, what you're going to do is leave the head inside your skin. You want to make sure that you remove the entire tick. There are lots of different tools that you can go out and buy that do this, but tweezers work just fine. How do you know then if you have a tick-borne disease? Well, let's discuss Lyme disease. When it comes to Lyme disease, for a very long time, Lyme disease was an intreatable disease. People suffered from chronic Lyme. Nowadays, that's not the case. Yes, there are lots of people who have Lyme disease, but typically those folks have had Lyme disease for quite a while. Nowadays, if someone comes in with vague flu-like symptoms after being exposed to a tick, you're going to get what's called a Lyme titer, meaning they're going to test your blood to see if you have Lyme. It's standard practice, especially in the Northeast. And then they're going to give you a standard treatment, doxycycline, that will take care of any problems you have, so you don't have to worry about it. If you come in and you have Lyme disease and they catch it, they're going to give you a course of doxycycline and it's treated. The problem comes if they don't catch it. But that's rare now, again, especially in the Northeast, because it's tested for regularly. The other thing to think about with ticks is just because you were bitten by a tick doesn't mean you have a disease. In fact, a tick needs to be on you for at least 24 hours, if not 48, before it can transmit disease into you. So if you are out hiking and you come home in the evening and you find a tick on you, simply remove it, you're fine. Also, a bit of advice. If you do end up going to the hospital or the ER because you're worried about a tick-borne disease, don't bring the tick with you. If they don't want it, they're not going to use it. Just leave it at home. Put it in the toilet, flush it down. The other thing to think about with tick is that you might get that bullseye rash that people think about. Well, if you see one of those, that is a sign of Lyme disease. However, if you don't see one, it's not necessarily a sign you don't have it. That bullseye rash only occurs in about 50% of the people. Let's talk about scorpions. Scorpions can inflict an extremely painful sting. However, they're very rarely deadly. Typically, like most things, they're deadly when you're dealing with very old, very young, or people who have chronic underlying conditions. When it comes to scorpions, what it means is you really have to check for them. They like to hide out in your boots, in the bottom of your sleeping bag, in your tent. So just check to make sure they're not there before you put those things on or get into them. With a scorpion sting, there's not a whole lot you can do. It's palliative care. Just simply make the patient more comfortable and then watch for any adverse reactions. If they start to get worse, then evacuate. Or if the pain is too bad, you can evacuate. Other than that, not a whole lot we can do. We'll move on now to spiders. In North America, and that's the ones we're going to talk about, there are really two spiders that we're concerned with in terms of envenomations, and that's the brown recluse and the black widow. If you're going to travel to other parts of the world, they have other types of spiders and other types of animals that can cause envenomations. You need to learn more about those. We're specifically going to talk about the North American ones. The brown recluse spider is a small brown spider. This spider has what's called a hemotoxin in it. Now, there are lots of other toxins and combinations of toxins that go there, but we're going to put it in the category of hemotoxins for simplicity's sake. What a hemotoxin does is it actually breaks down the blood and the tissue inside the victim, therefore liquefying it. That way then the animal can eat it. Now you have to remember, a brown recluse spider is very small. It's meant to eat very small prey. When it bites you, it's not going to eat you. If you are bitten by a brown recluse spider, you may not even know you've been bitten. What happens is several hours after being bitten, you start to see what looks like a wound that may appear. It gets red and angry. You might not even know that you've been bitten by this spider, and so you might not go seek care. Over time, however, hours to days, this wound will start to become what's called necrotic or dead, because the tissue is being eaten away. You're just going to treat this like any other wound. As the wound progresses, it can become more necrotic. What that means is the tissue starts to die. As it dies, you can get infection, you can get gangrene, and lots of other complications. Hopefully by this point you've recognized that this is a big bad wound and you need to get out. But you're just going to treat it like any other wound. If you know you've been bitten by a brown recluse spider, then you should start moving towards the front country. Again, it doesn't necessarily mean you're going to die, but you don't want to lose a hand or a toe or a finger for waiting. On the other side, we have the black widow. Now, the black widow has a very bad reputation as a killer. It does have a more powerful, different type of venom, and that's a neurotoxin. Again, lots of toxins in there, but for simplicity's sake, we're going to keep it at a neurotoxin. What this does is it affects the nervous system. What a black widow spider is trying to do is when it bites, it paralyzes the diaphragm to stop the victim from breathing, killing it, and then it can consume it. Again, you are much bigger than a black widow. Very unlikely to die from a black widow spider bite unless you're in one of those at-risk categories. Again, you may not know you've been bitten by this. Their bites are very, very faint, but you may experience abdominal cramping, difficulty breathing, anxiety, nervousness, pale, cool, clammy skin. If those things start to happen and you've been bitten by a black widow, then you need to start your evacuation. Other than that, there's nothing we can do for these. It's just palliative care and monitoring. Sticking with those categories of hemotoxins and neurotoxins, we move into our snakes. In North America, we're dealing with pit vipers and the coral snake. The pit vipers encompasses a large group of snakes: cottonmouths, water moccasins, rattlesnakes, copperheads. All of those are pit vipers. They're called pit vipers because they have heat-seeking pits on the side of their head. They have diamond-shaped heads. That's how you can recognize them, although I don't plan on ever getting close enough to do that. What they do is they inject, again, a hemotoxin. Now, these are larger animals. They're used to eating larger prey, and so they can cause a lot more damage. Very, very unlikely to die from a pit viper envenomation, but their progression for wounds and wound necrosis can progress very, very rapidly. If you've been bitten by a pit viper, the treatment is palliative again. Nothing much we can do. Don't put ice on it. Don't put a tourniquet on it. Don't wrap it up. Don't cut and suck. If you've ever seen any of those suction snake bite kits, they are complete snake oil. They're not worth the plastic they come in. You're simply going to take care of your patient, monitor their vitals, and get them out to further care. On the other side is the coral snake. And the coral snake is the neurotoxin. Now, of all the animals we've talked about so far, this is the one that has the potential to kill. This neurotoxin is extremely potent. Luckily, they're very shy animals. I still don't want to encounter one. You can tell a coral snake by its colored pattern on its skin. There's a saying that goes, red on black, venom lack. Red on yellow, kill a fellow. What that means is if you see a snake and its red and black stripes are touching, that's a mimic. It's not a coral snake, it's just trying to fake you out. If you see one with red on yellow, that's a coral snake. It can kill. Now, most snakes that are poisonous have fangs, meaning they leave 2 bite marks in a patient. The coral snake, however, has teeth, and in fact, it has to chew on you to get its saliva into the system to cause its poison to go in. Like I said, these are extremely venomous. They cause diaphragm paralysis. You're going to get those same things with the black widow: difficulty breathing, abdominal cramping, nausea, vomiting, but this is going to happen much more rapidly, and there's a high likelihood of death. What are you going to do? Try to get out of the woods as fast as you can. If you can identify the snake or the spider that bit you, that's great. If not, don't try to capture it. You're probably going to also get bitten trying to capture it. You don't need to bring the animal with you. Simply try to identify it the best you can and then get to the hospital. We now move into wasps and hornets. When it comes to wasps and hornets, yes, there's some danger of anaphylaxis, which we'll talk about in a moment. But the bigger danger is wasps and hornets can sting multiple times. Unlike a bee, which can sting once, and then when it comes out, the stinger is removed from the abdomen and the bee dies, wasps and hornets can sting you again and again and again. Where the danger comes is you get 50 or 100 or 200 stings, and you get an overwhelming body response. But if you're simply stung once or twice by a wasp or a hornet, there's really no danger in death. You're simply doing, again, palliative care, taking care of the patient, maybe some pain medication for them, and ice on the sting spot can help. When it comes to bees, because they leave their stinger inside, you need to remove the stinger. Once a bee stings you, as I mentioned, when it flies away, the stinger stays and the bee dies. The venom sacs are attached to the stinger. Those venom sacs continue to pump venom through the stinger into your skin. How to remove this? Simply scrape along the skin to get the stinger out. What are we concerned with bees? Well, it could be just a bee sting, and you want to use ice, palliative care, or it could be anaphylaxis. So we'll talk about anaphylaxis. So anaphylaxis can be caused by all sorts of things. It can be food, it can be environmental, it could be drugs. Anaphylaxis is a severe allergic reaction. It's what happens when a person's body overreacts to some contaminant that's coming into it, to an allergen. Now, a regular allergic reaction is when your body recognizes an allergen and it releases certain chemicals to wall it off, to send things to fight it, to stop your body from reacting. What happens is your body releases histamines. Those histamines cause certain things. They cause vasodilation, or blood vessels to get bigger. They cause your blood vessels to get leaky, so fluid can move in and out. Now, in a regular person who's having a regular allergic reaction, that is a localized spot. You get stung by a bee, you get a raised red welt on your arm or your hand. You have seasonal allergies. You get watery, runny eyes and stuffy nose. Those are all caused by histamines. The person who is anaphylactic, what happens is they don't get a local reaction. They get a systemic reaction. What I mean by that is instead of getting a reaction at the spot where the bee stung them, their entire body reacts. Instead of releasing histamines here, they release histamines everywhere. So every blood vessel in your body opens up. Every blood vessel in your body becomes leaky. Your airway passages clamp down. What goes on is your blood pressure starts to tank and you can't breathe. The definition of anaphylaxis, what you're looking for, is breathing difficulty. Airway swelling, breathing difficulty. This is really important to understand. If you think someone's having an anaphylactic reaction, yes, we can treat it. But we want to make sure we're treating it because we actually think it's anaphylactic, not just because we're scared. People can have severe allergic reactions where they get hives all over their body. But if they are not having breathing difficulty, it is not anaphylaxis. Anaphylaxis is defined by breathing difficulty. Why is this important? The treatment for anaphylaxis, by definition, is going to equal an evacuation. You do not stay in the woods if you believe someone's having an anaphylactic reaction, even if they get better after treatment. If we think they're in anaphylaxis, they need to get out, even if they get better. Think to yourself, just like a heart attack. If they're having a heart attack, we leave the woods. If we think this is anaphylaxis, if we treat for anaphylaxis, we're leaving the woods, regardless of what comes next. So, how do I treat for anaphylaxis? We're going to do two things. They both have a role to play. One buys us time. One actually works on the mechanism to stop the reaction. The one that buys you time is going to be an epinephrine autoinjector. Now, I have a few here that I'm going to show you, but there are lots of different brands out there. This just happens to be two of them. This is probably the most common one. It's an epinephrine autoinjector, meaning this contains epinephrine. Epinephrine is commonly known as adrenaline. What does this do? Well, what this does is it takes your blood vessels and makes them smaller. That way, it keeps your blood pressure up. And it takes your airway passages and opens them up so you can breathe again. This does not cure anaphylaxis. It simply buys you time to get something else on board that's going to really help out. How does this work? You twist off a safety cap, you take off the top safety, and then it goes in the thigh. It's designed to go through clothing. You don't have to get down to skin. You don't wind up and slam this thing in. You simply put it here and push. Hold it for about 5 to 10 seconds, and then remove it. You can rub the area to help distribute it and with some of the pain. But once it's in, it's in. The nice thing is there's a safety and you can't access the needle anymore. This is the newer version. You may still see this one out there of this particular brand. It looks the same. You notice how I'm holding it, always around like this. Never hold it like this. In the moment, you're probably going to be panicking. And if you hold it wrong and put your thumb over this end, you're going to send a needle right through here. This is another type of epinephrine autoinjector that you might see. It looks very different, but it functions exactly the same. You take it out of its case, you place it against the thigh, you push it in. Now, these are going to be things that the patient would have. So you would find this with the patient. If you believe that the patient is having an anaphylactic reaction, and again, that's defined by what? Breathing difficulty or airway compromise. Definitely administer this. Epinephrine works very rapidly. It will start working within a minute or two. The problem is it wears off very quickly, 10 to 15 minutes. It only relieves the symptoms. So what else do I need to do? This whole process is caused by histamines, so I need to get an antihistamine on board. The most common one that you're going to use is diphenhydramine. Now, diphenhydramine is the drug name, so you can go find that drug. But diphenhydramine is an antihistamine. You'll get this on board. The dose for this is 50 milligrams. They can take this. This will stop the histamine reaction. However, it takes about 30 minutes before this starts working. Well, if epinephrine only lasts 10 to 15 and diphenhydramine takes 30 to start on, what might you need to do? You might need to give them another dose of epinephrine. This is why they always come in 2-packs. If they start having signs and symptoms again of anaphylaxis, give them another dose. Hopefully then the antihistamine will kick in. Even if they get better though, you are still leaving the woods because the odds are they're going to need much more epinephrine. They're going to need further treatment and care with steroids. They need to get to a hospital, an ambulance, an emergency room. The number one reason why outdoor trips are called off, canceled, and patients are evacuated unnecessarily is the misuse of epinephrine in the backcountry. Again, if you think you need to use it, go ahead and use it. The worst that happens is you just have to leave. But we want to be good medical providers, so look for the proper reaction. If you're not having breathing difficulty, then you can just give them the antihistamine and then monitor your patient. If they get worse, give them the epinephrine, evacuate your patient.